All right, well, why don't we go ahead and get started? I'm sure people will still continue to make their way in from their last meeting. So, hi everyone. Thank you for joining us today. I'm Nicole, a continuing education coordinator for the collaborative. And please feel free to submit your questions into the chat or Q&A at any time. And Dr. Pearlman will address your questions at the end of today's presentation. So I would now like to introduce our speaker, Dr. Stefan Pearlman. Dr. Pearlman joined Christiana Care as a staff neonatologist after completing his fellowship at Penn State Hershey. He has held several leadership positions within the Department of Pediatrics, including Associate Director of Neonatology, the Director of Pediatric Medical Education, and served as the Neonatology Fellowship Director. He is currently the Clinical Effectiveness Officer at Christiana Care Health System. And in 2024, Dr. Pearlman is the recipient of the Avery Faneroff Neonatal Education Award from the American Academy of Pediatrics. And so we are thrilled to have you with us here today. Welcome, Dr. Pearlman. And with that, I will pass it over to you.
Thank you, Nicole, for that kind introduction, and thank you all for inviting me to speak on this important topic. What I can say is I don't consider myself an expert in this, but we have a fair amount of experience in this area because we've had our CRP Candor program up in operation since 2015. So we certainly have dealt with how to engage our clinicians in that process, and we've learned some things along the way. So I will present my material, and I look forward to addressing your questions at the end. So just so you know a little bit more about Christiana Care, we are a large tertiary teaching hospital affiliated with Thomas Jefferson University in Philadelphia. Delaware is, I think, the only state in the United States that doesn't have its own medical school, but instead the state government appropriates funding to Jefferson Medical College so that Delaware residents can attend medical school there. We have three clinical campuses, acute care hospitals, two in Delaware and one in Maryland. And we have a freestanding emergency room as well. We provide acute care as well as ambulatory care. We have a lot of ambulatory practices across the tri-state area. And we have a blend of medical dental staff, which may be different from what some of you have. We have some clinicians, close to 1,800, who are employed by the hospital. We have close to 900 who are privately employed. And then there are close to 300 who are contracted, which is just a way that the hospital sort of divides it up. In other words, they are privately employed, but they have an exclusive contract with our institution. And as I said, we began our Candor program in 2015 after having gone through the demonstration project through AHRQ together with Dignity Healthcare, which is now Common Spirit out in California, and MedStar in the Washington, D.C. area. One thing I will point out is that we defined a Candor event perhaps differently than you might, or that other institutions might. Because we were starting this program with limited resources, in other words, just with existing resources, we weren't given any new resources. We define a Candor event as one involving a patient that experienced an unexpected death or permanent harm. And that was probably one of the best decisions that we made, because we've certainly seen a lot of cases that fall into that category. And if we had a broader definition, I think we would never have been able to handle the load with the existing personnel. So to borrow the phrase mission critical from one of Tom's articles a number of years ago, I think that clinician engagement is really critical to establishing and maintaining your CRP. And the reason for that is that clinicians, they know the clinical care or the clinical course of a patient. They know the facts that are essential to the review that others may not know. So you need them involved in the review process. They can serve as content experts, that you may need an opinion from a cardiologist about a particular case, even though cardiology wasn't the primary service involved in the patient's care. And so involving other people from the department, that helps build engagement also because they realize that that somebody from their department was involved in the review process as a content expert. And also they're critical to the success of your program because they know the patient and the patient's family. They have a pre-existing relationship with them that other people don't necessarily have. So for all of those reasons, I think engaging your clinicians is so important. And we've taken sort of a multi-dimensional approach to engaging them in our process. We've done a lot of education, and I'm going to go into some of these things in a little bit more detail. We've used simulation at times. We get feedback from them in terms of how they feel about our process. We engage their department leadership and the organizational leadership to help with clinician engagement. If you have leadership support, that will help drive clinician engagement as well. Sometimes we have to deal with them one-on-one to address specific barriers. And it really is very helpful. And we did a lot of groundwork on this at the beginning, as many of you have already probably done, to get the support of the insurance carriers in your area. If they buy into the process and they represent certain clinicians that you're dealing with, and the defense attorneys, they will also help drive engagement of your clinicians. And because we're dealing with, about a third of our medical dental staff is privately employed, and they have their own insurance carriers and what have you. If they're on board with you, that can really help support the process overall. What are the biggest challenges? Well, fortunately, candor events are not everyday occurrences, at least the ones by our definition. So an individual clinician may never be impacted by this process, or they may have, been impacted once and never again. But regardless, it's pretty unusual for the same clinicians to be involved in multiple events directly. So that means that people aren't that familiar and may need more or recurrent education about the process because they haven't been involved recently or at all in the candor process. So when you call upon them to get involved with reviewing a case or whatever, you're asking them to serve the process with it may be challenging. Also, I don't know about your places, but we have a lot of new staff. We've onboarded several hundred new clinicians in the last couple of years. And just in the past few months, we've onboarded, I think, 25 new clinicians in the emergency department. So that turnover, again, is a reason why you have to constantly figure out ways to engage these people and make sure that they understand the process that you have. Despite all of our efforts, and this is not something that's unique to the candor program per se, but some people believe that the process is punitive, much like people may be skeptical to report events in your reporting system because they think the whole thing is punitive. Um, uh, there are concerns about the candor process being that way. I've already mentioned the non-employed clinicians. They are a little bit more problematic because, as I said, they have their own insurance carriers. Those folks may not be willing to, engage in this process, and that's problematic. If you've gone through an entire evaluation and your conclusion is that we collectively caused the harm to the patient and you're planning on offering compensation, if their insurance carrier doesn't want to do that, you have an issue. So we've had to figure out, how to really engage those folks. Whereas the people who work for the hospital system are covered under our insurance. So that's a little bit easier because obviously our insurance carrier is supportive of this approach. And so that's kind of, the last two items on the list are kind of linked to one another. So what did we do, from the beginning? How did we lay the groundwork for this? Well, we made sure that we had leadership support. As a matter of fact, we would not have even gone through the ARC project had it not been for the fact that senior leadership was aware of these types of programs and wanted to get involved and wanted that to be the approach that was taken at Christiana Care, a proactive approach to patient harm. And the other thing I will mention that can either sink your program or make it successful is that it requires a collaboration between people who work for different parts or different departments within the hospital who have really very different lenses how they look at safety events. Patient safety people look at it almost from an RCA standpoint, where they want to figure out what the root cause is and figure out mitigation strategies to prevent these things from happening again. Risk managers may look at this a little bit more from the perspective of an event being a potentially compensable event. And patient relations put themselves, I think, in the position of the patient or family so that they can be as supportive as possible. So how do you get these people with divergent views of the same, same types of issues? How do you get them all on the same page? And we worked very hard at that at the beginning. We had different types of meetings. We even had a retreat with a facilitator to try to help everybody get on, be able to see things from others' perspectives, and that was very successful. I think we have a well organized team now and a very cohesive team now. And then we did some external work, and that is when we started talking about this, we had seminars for the insurance carriers and external plaintiffs' attorneys um, who work in our area. Now, granted, Delaware is a little bit of a smaller area, maybe compared to some of the areas that you work in, and it may be a little bit more challenging to do that. But I think that helped a great deal with getting our program off the ground. So I'd have to say that education is the key in terms of your clinicians. We sought to address any misconceptions, and the way we did that was we had at the beginning both internal and external speakers. Sometimes things are better received when you have a visiting fire person come to your institution and talk about it. Sometimes it's heard a little bit differently from your staff compared to somebody internal. So we did both. And we did, grand round style lectures for different departments and events that we did, seminars in the evening, when clinicians who were busy in their office could get there, and had external speakers and served dinner and those types of things to really get people on board. We also created some self-guided modules. I'm not sure what your system has, but we have like a learning center, and we have a whole department that helps develop these things. Certainly, I'm not knowledgeable enough to know how to do that on my own, but we gave them the material. We developed a slide set, and these modules are basically slides with a voiceover, some interactive things as part of the learning module, that people can do at their own pace, whenever they want to. We don't actually require people to do it. We put it in their learning center when they are onboarded. There's a whole module about the Candor program that they can do, and there's also a module about communication skills related to disclosure. In addition to that, at the beginning, we ran communication training sessions. These were done with small groups of clinicians from different departments and different service lines. That it was a situation where we were training the trainer, that these people would then go out and train others within their department. We haven't repeated that. We've kind of moved more in a direction of individual one-on-one disclosure training. So when a clinician is tasked, because they have a pre-existing relationship with the patient or family, to reach out and tell them that we're going to be performing a system level review of the care, I or somebody else in a similar role to me will get on the phone with that clinician and kind of walk them through what they should be saying, and frankly, what they shouldn't be saying. And we do have a tip card that we also send out to clinicians. So there are a variety of ways that we help them with that type of communication, which is for some a new skill set. And we did incorporate it into simulation training in certain departments that wanted it. We embedded some scenarios where we had a hypothetical patient. We do have a very well-developed simulation center, and we use actors as simulated patients, and we developed a couple of scenarios to help people learn how to disclose to patients. And the disclosure coaching, by that, I mean the one-on-one stuff that we're doing more of now. Now, my experience is that clinicians are very much data-driven. And maybe that's not true for all clinicians. I could be wrong about that. But many, I think, are. I think that stories also help to resonate with clinicians, but I tend to do more of the data when I talk to groups of clinicians. I share both the published outcomes from other centers as well as our own local results, so that people know, how many cases we're seeing, what the outcomes are, what's happening in terms of our medical legal outcomes, et cetera. And they need to understand that most of these programs have been shown to reduce medical legal risk. Also, they're always concerned about, anger and frustration being vented at them if they, talk to a family and disclose that, this was not an outcome we're expecting, and we're going to take a look at it. But in fact, experience both at our institution and elsewhere is that this type of program actually improves trust with our patients and their families. And I think one of the really important things is that these programs allow clinicians to be supported throughout the review process. What used to happen was that, in the old deny and defend type of modality that existed in the past, and that I and many others were trained during that time period, you were told not to talk about these events to anybody, including your closest friends and significant other. And so as a result of that, many people suffered in silence. Sadly, some of those people did harm to themselves, and that's a terrible thing. We've even had clinicians who have taken their lives because they couldn't live with the fact that they made an error that led to a bad outcome for a patient. So by having a more open discussion about these cases, it allows us to have to support these people. We have a very strong peer support network called Care for the Caregiver. It was actually started by a clinician, one of our emergency room physicians, who she herself was involved in an event, and she was so upset and ultimately depressed about it that she contemplated leaving medicine entirely. And when we engaged with ARC about the Candor program, she came and joined us and actually developed the Care for the Caregiver program at Christiana Care, which is still a very strong aspect of our CRP. So removing barriers very often means, you have to make sure that people understand the process. And it's this lack of understanding that sometimes leads people to, have misconceptions. So how do you do that? I think that one way to do it is to employ champions. So if you can identify certain people from certain departments that are supportive of your process, use them to talk to other people within a department. It's very helpful when it's coming from a colleague, and it helps to break down the barriers and eliminate some of that resistance that you might be encountering. Educate people, in other words, keep it going. And when we recently had, what I affectionately refer to as a minor insurgency with some of our non-employed physicians, I started doing a whole series of lectures again to a number of different service lines around my institution. So education can really help, and also just making it your new normal, making it like, okay, guys, this is the way we do things. This is the Christiana Care way. This is part of our DNA now, and then it'll become accepted over time. And recently, because of some of the pushback, people don't always understand why they're being invited to debriefs, why they're being invited to meet back with the family, how the whole process works. We created some new communication tools so that when somebody is invited to one of these things, this communication goes out with the invitation so that they know and understand exactly why they've been invited. So part of the barriers are related to a lack of trust. And this is a hard one to eliminate. There are, and I have friends who are in private practice in this community, and many of them are mistrustful of the hospital. And they think that when push comes to shove, that the hospital is going to, favor their own interests over the individual clinicians. So you can only counterbalance that, I think, by showing them evidence from other cases and having them speak to colleagues that that is not the case, and that we present ourselves, even when it's a privately employed clinician, that we always present ourselves to the family as a cohesive team, and if we found that we, were responsible for harm to the patient, we acknowledge that as a team and not pointing to individuals. Again, education helps to build trust. Um, and if you approach the review as an interdisciplinary process, and by that I mean you involve the clinicians in all the steps of the review process, then as well as nurses and respiratory therapists and other caregivers who are involved in the patient's care, uh, then it sends the message that we are a team and we function that way, and we are going to review it as a team and find our system opportunities. And again, referring them to patients who have been to other clinicians who have been involved in other cases, have had a positive experience with the Candor program. That helps to build more trust in the whole system. Sometimes they feel unsupported. They feel like they're going to go into a meeting and that they're going to get hung out to dry. If you involve the people that they work with otherwise, within their department, either the people who are leading the event review team, the risk manager, the patient safety people that work within the department, then I think they will feel more supported and not alone in the process. What we've learned with the Care for the Caregiver program is that very few people reach out on their own to get that kind of peer support. I don't know. I guess it's that as clinicians, we think we're tough enough that we don't, that asking for that kind of help would be a show of weakness. So we try to identify people during the initial call that we have where we discuss the case, or during the debrief itself. We try to identify clinicians and gauge their, emotional state. And if we feel that they need to reach out, we proactively reach out to them instead of waiting for them to contact us. And there are also times when we, reach out one-to-one and give them the support that they need. This is very hard for some clinicians to openly engage and talk about a bad outcome. They just it's a very different paradigm from what they've been used to. Part of their concern is fear of litigation, and what we heard over and over again at the beginning was that, if the patient or the patient's family didn't ask to meet with them, why are we meeting with them? We're just going to be creating more trouble, and we're going to increase our risk of being sued. And, the literature speaks against that. You can certainly share the information from the literature, but now, not I wasn't able to do this at the beginning, but now I can also share the results of our own medical legal outcomes, which are also favorable. Or again, you can talk about particular cases, or have them talk to people involved in particular cases where they had a positive experience. And then I think it also is very helpful, and we've made a strong effort at our institution to separate event review from peer review. And that obviously, is not always that easy to do. So for example, I always use this as extreme example. If we remove the wrong kidney from a patient, this is not a real example, by the way. And if we remove the wrong kidney, but we didn't find any system opportunities, in other words, it was really an operator error, we're not going to walk back into a meeting with the family and tell them we did a thorough review and we did everything absolutely right. So there is an element where you have to bring back in sometimes some of the peer review as well when you're at the end of your process and talking with the patient or the patient's family. We've had experience where clinicians disagreed with the conclusion of our analysis, and one of the recent cases we had, we were at fault, I think, because we had not really involved the departmental event review team as much as we should have. If we had integrated them better into the review process, I think we would have gotten more factual information about the case, and we would not have ended up in this situation where the clinicians disagreed with the conclusions that we had come to. Again, utilizing their own colleagues, maybe people in their own practice, their own division, their own group, as content experts helps to build credibility for your program. We always, before we meet back with the patient or the family, we have what we call a pre-family meeting. And that's where we hash these things out. That's where we sit down and say, okay, this is what we learned during our review, and this is what our message is going to be to the family. And then if there are people within the group who disagree with that, we hash it out and try to come up with a unified message when we do meet back with the family. We do not want to get into the room with the patient or the patient's family and have people disagree with one another. And then we always have the clinicians be the ones to share the results of the review back to the family. I'm at the meeting with the family and I introduce the process and explain why we do things this way. It's part of our commitment as a learning institution, but I do not share the actual learnings from the review process. We let the clinicians be the ones to do that. We seek feedback in a variety of different ways. So first of all, every time we have a debrief, every debrief participant gets a brief survey that they fill out. We ask them, are they satisfied with the process? We ask them if they think that we maintain psychological safety during the debrief, and whether other members of the team who are at the debrief also maintain psychological safety. And I can tell you that around 97% of the responses we get back are favorable. I always wait after the family meeting has occurred and the family has left. I stay back with the involved clinicians and I get some direct feedback from them in terms of how they think the family meeting went. I think that's very helpful. And also you can gauge whether they're in need of additional support. And one of the things that we haven't really been able to do is get sufficient feedback from the family. And that's because our risk and legal department is kind of hesitant for us to reach out to families too soon after these meetings because we don't know if they're going to ultimately take legal action or not. So this is a big paradigm shift in how you approach things, and I think all of you are at different places in that shift. I recently read a book. It's not that new a book, so some of you may have already read it also, called Switch. And it's just one model for change management. I like Kotter's model also, but in terms of how you get people on board and how you get them to change and how you engage them, you can use some of these strategies. They talk in their book about the rider is the rational side, and basically they say, start small and build on what works, build on your successes, work on specific behavioral changes that you need, and be very clear and intentional about what the destination is for your process. The elephant is more the emotional side. And that's where I think storytelling can be very valuable when you talk about a case and you see what the outcome was, you see that the clinicians did not have to be deposed or go to court. You see that the families were satisfied with the process. That can be very useful in terms of appealing to people's emotional side. You can use incremental change, small changes at a time instead of going full throttle, and instill a mindset that growing this program is really important. And then the path is what they define as the situation, which is how you can make it easy for people to do the right thing and to make behavior habitual, and this type of behavior becomes contagious. I certainly think that that is true within our system. We're not at the same place we were at when we started the program. So many people now have been touched by candor in different ways that there it is pretty clear to folks that this is the way we do things around here, that we're much more transparent and much more communicative with our patients and their families. So one of the quotes I liked from the book was, "What looks like resistance is often a lack of clarity." So again, that means educate, 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 meet with people, talk one-on-one, use your champions to drive your point home and to get people on board. So in conclusion, I hope I've convinced you that clinician engagement is essential to your CRP success, that ongoing education is the key strategy, even for mature CRPs like ours, which, I learned that lesson recently the hard way, that you have to continue to educate people, continue to tell the story. And success, if you're successful, and I think our program has been successful, it will drive more success. So utilize your champions, utilize your leaders. You're not going to be successful without them. Use storytelling and other strategies to continue to drive engagement, and use change management strategies to help with this paradigm shift that we're all a part of. That is what I wanted to share with you today. I hope it was useful, and I'm happy to try to answer any questions.
Thank you so much, Dr. Pearlman, for that wonderful presentation. We did have some questions come in while you were speaking, so I will try my best to go through those in the order that they came in.
Okay.
First question came from Lori, and she asked, is there any movement with waivers for participating in the Candor program with regard to reporting any compensation to NPDB?
I missed the very first part of the question. Say it again.
Oh, is there any movement with waivers for participating in the Candor program?
I'm not aware of waivers. I think that if the patient or family, as part of the resolution process, if they make a claim and they name a particular clinician, then that is reported to the data bank. That's my understanding. If somebody has a different understanding, who's on the call today, please speak up. I'm happy to hear other opinions on that. I'm trying to see okay, I need to stop sharing. Here we go. All right. Next question. Other comments or questions?
So we have a question from Maha, and Maha asks if you could please talk more about the self-guided modules. How are those run? What type of content is included? If you can have any more information you can share about those.
Yeah, it's interesting. So somebody heard me give this talk at the PAC Collaborative, actually reached out, and earlier today I had a virtual meeting with them, exactly the same question. So we developed them. we have two modules actually. One is sort of an overview of the candor process. It gives some of the background to how these programs develop. It talks about the various process steps in our process. And it's a little bit of a longer module. Again, we have a department that helps us to develop these things. So we develop the content, the slide set, and then we had to, work with them to do the voiceover that goes along with it. The second module is more about communication skills, and that's a little bit shorter. We talk about what the various things are during an initial disclosure that you should be saying to families and what things you shouldn't be saying to families at that particular time in the process. These are things that people can do on their own at any time. They're available within our learning center. As I said earlier, our hospital is reluctant to make any of these educational things mandatory unless unless it's something that's required by a regulatory body like the Joint Commission. So we have these things available. We do assign the module on the overview of the candor process to all new employees. So it pops up in their learning center. It doesn't mean that it's mandatory that they have to do it, but it sort of makes them aware that it is, that it's there. The other one is completely like on your own.
Thank you. Let's see, we have another question from Ryan. So Ryan asks Ryan is curious to what extent you utilize the experience of patients and families in the review process. So just talking to them about what they saw, what they heard, what they thought, incorporating that kind of into your event review process.
Sure. We absolutely try to incorporate the patient experience into the review process. And we do that by having people ask them at the time when we do the initial disclosure, is there anything that you were aware of, anything that you saw, or do you have any questions about anything that happened, before the event actually occurred? And then during the review process, while we're going through our review, our patient relations people who act as the patient or family liaison, they try to get additional information from the patient or the patient's family regarding what they know or what questions they have. So those are the main ways in which we try to gather information. I can tell you that despite our efforts, there are times when they ask questions once we meet back with them that they haven't mentioned before. I don't know if that's because they want to catch us off guard. I hope it's nothing as nefarious as that, but I think it's sometimes that something that we have said during our presentation to them sort of jogs their memory about some aspect of the event, and then they have a question that they haven't even thought of before. So we also created a written tool that's pretty easy to fill out that we send to folks electronically, asking them what they saw, what they knew, and what questions they might have. So we try to do it in a couple of different ways.
Great. Let's see, we have a question from Dr. Gallagher. So Tom asked, despite your best efforts, an involved clinician may fundamentally disagree with the conclusion of the event analysis. When this happens, do you exclude them from the discussion with the patient and family?
You always, you made me a little nervous when you said it was a question from Tom. So no, we would never exclude the clinicians involved from, from the speaking to the family. We sometimes have to involve departmental leadership to work together with those clinicians and us so that we can come to an agreement on what what the message is, what the review process showed. And usually we've been successful with those efforts, but we would never not have the clinician there. The only instance I can remember was a clinician. It wasn't because he disagreed with the process, but he was so emotionally distraught by what happened and had already spoken to the family at the time when the event occurred, that he just didn't feel emotionally that he could go through with being there at the family meeting. And he actually, we had a leader from his department come instead.
Yeah, our next question comes from Robert, and Robert asks, when a settlement offer is made under candor, do you find it helpful to get a third-party mediator involved?
Okay, so my background is clinical and patient safety, and I think that's more of a question for risk and legal. I um, I think, you know, that they do go through a mediation process. I don't know if that means that it's just a discussion between our insurance carrier who has, we have somebody that reaches out who's very experienced with having these types of discussions, or if they bring in a third party. I will say that very often, when we're planning on offering a compensation, we will consult with an outside expert ahead of time to get a better understanding of what the valuation of the case should be. But whether a mediator gets involved in the negotiations, I don't actually know. I don't know also if there's somebody else on from risk management or legal from Christiana who tuned in today, who maybe has a better answer for that than I do. I apologize. Just not my. I don't. Once we've met back with the family. And if the plan is to offer compensation, I'm pretty removed from that part of the process. That's really something that our insurance carrier and the risk and legal department handle independently of the other components of the process.
We did have a couple more questions related to the educational tools that you have. Sandy was wondering if you're able to share the physician tip sheet that you mentioned. And then Linda is asking if the modules are available. I'm guessing the self-guided modules are available for use or purchase. I think there's a lot of interest in the tools that you are using.
Yeah, thank you for that. You've just given me a business idea here. I'm happy to, if anybody wants to email me, I should have put that up on one of the slides, but my email is sperlman, Pearlman, at christianacare.org. I'm happy to share that. As Tom just said, there is a communication tip sheet that is part of the PAC Collaborative has that available. ARC also has that as part of their tools, as part of the toolkit that was developed. And so I think that ours might be a little bit of a variation on the theme, but basically, if you look at the ones that are available through PACT or ARC, you'll be able to develop one that suits your own needs. In terms of the modules, I I I don't know that I have the ability to share them, honestly, because they're things that we created and are embedded in our learning system. I would have to look into that a little bit more, and I will do that. And then if I'm able to do it, I will reach out to Nicole with that information.
Great, thank you. And let's see, Lori is asking, do you find new clinicians either in their post-medical school education or other organizations lack knowledge of CRPs?
Say it again.
So are you finding that when new clinicians come to Christiana Care, are they lacking knowledge and background in CRPs, or do they come with kind of a knowledge base?
Uh, I wouldn't say that this has gotten to the point where it's part of medical school curriculum. I mean, we do expose our residents to it. We involve them in the process. We have them, come as observers. Uh, if if they're coming because they were involved directly in the care of the patient, we always make sure that their residency director is at the meeting with them to provide support throughout the review process. If you think it's difficult for a seasoned clinician to come to one of these meetings and discuss what went wrong, it's probably even harder for a house staff member. I think our house staff, um, I think when they start out, their biggest fear is that they're going to make a mistake. So, if they're involved in one of these reviews, it may be a realization of that fear. So I don't think that it's something that they know at the medical school level. We are trying to educate our residents in our program about this approach, and many of them get exposed to it. We give them lectures about it. They get involved in various meetings as appropriate. So that's the way we've dealt with that. And we have approximately 300 house staff at our institution in a variety of different medical specialties.
Well, I think that covered all of the questions that we had come in today. So with that, Um, yes, there's definitely an opportunity for that to be included in the medical school curriculum. But I think that answers all the questions that we had today. Dr. Pullman, I want to thank you for sharing your wisdom with our community today. And for everyone in attendance, this webinar will be recorded and available on our YouTube channel if you want to share it more broadly. And if you have any follow-up questions, you're welcome to reach out to me, Dr. Pearlman, or Dr. Gallagher, and we can connect you with what you need. So thank you, everyone. And with that, have a wonderful day.
Thanks, everyone.
Take care. Bye.